So good afternoon, everyone, and thank you for joining us for our second workshop for this rulemaking. My name is Amelia Boyd, and I'm the program manager for the WMC. I will be facilitating today's session along with my co-organizer, Bonnie Gregory. This workshop is being recorded, and we'll post the recording to our YouTube channel soon. The documents we'll be discussing are available on our website at wmc.wa.gov. In this slide deck, the globe, which links to our website, and YouTube icons are clickable and will take you directly to those resources. For attendees, if you'd like to ask a question or make a comment, please use the raise hand function. We'll call on you as soon as we can. When offering comments, please avoid reading aloud any written remarks that are already included in the materials. These workshops are intended to be collaborative with a back and forth exchange of ideas about the proposed language. So before we get started, I'll take a roll call of our panelists and staff. When I call your name, please introduce yourself. Marlon, if you would go ahead.
Good afternoon, Marlon Basco. I'm a policy analyst with the Department of Health, and I support Amelia in rulemaking.
Thank you. Ms. Blake.
Good morning, Christine Blake. I'm a public member of the commission.
Dr. Chang.
Hello, good afternoon. This is Dr. Chang, Poshin Chang. I'm a retired family physician. I'm a commission member.
And Caleb Chu.
Hi, good afternoon. I'm Caleb Chu. I'm Associate Chief Medical Officer for Pacific Medical Specialty Group.
Thank you. Marissa.
Hi, my name is Marissa Courtney. I'm the licensing manager with the Medical Commission.
And Bonnie.
Hi, good afternoon. Bonnie Gregory, the commission meeting coordinator for the Medical Commission and assistant to Amelia Boyd.
Thank you. Kyle.
Good afternoon, everybody. My name is Kyle Kiernan. I'm the executive director for the commission.
Mark Lowe.
I'm Mark Lowe. I'm the executive director for the American Academy of General Practice.
Thank you. Micah.
Good afternoon. Micah Matthews, Deputy Executive Director for the Washington Medical Commission.
Oksana.
Good afternoon. I'm Oksana Nestorenko. I'm an Associate Chief Medical Officer in Clinical Operations for Pacific Medical Specialty Group.
Thank you. Dr. Fleming.
Good afternoon. I'm Stan Fleming. I'm the CEO and Chief Medical Officer for Pacific Medical.
Thank you. And then Dr. Domino, please introduce yourself and then begin the script.
Okay. Hi, everyone. My name's Karen Domino. I'll be the presiding officer for the rules hearing. And today is Monday, March 9th, 2026, and it is now 1:11 p.m. This meeting is being held by a Teams webinar. The rule being discussed today is regarding WAC 246-919-010 through 246-919-520 and WAC 246-919-602 through 246-919-700, which sets standards for allopathic physicians or MDs. The CR 101 or pre-proposal statement of inquiry was filed as WSR number 25-12-014 on May 22nd, 2025. Ms. Boyd, please present our proposed timeline for rule development.
Thank you. So here's our proposed timeline for this rulemaking, which may be adjusted as workshops are held. Does anyone have any questions about this timeline? If so, please use the raise hand function and I will call on you. No hands are raised. You can go ahead, Dr. Domino.
Oh, okay. Sorry, I was trying to get slides visible on my computer. It wasn't coming up. All right, well, thank you. The next item on the agenda is a presentation by Dr. Stan Fleming of the American Academy of General Practice.
I take it we're on.
Yes.
Do you have our slide set before I get started, if I might?
I do. Hold on just a second.
Chair Domino, while they're pulling the slide set up, I just wanted to let you and the commissioners know the presentation is going to include two parts integrated. One is about our particular MDCE program, and then AAGP and the importance of both of those as it applies to the rulemaking.
Thanks, sir.
And then with that, on as far as advancing slides, am I able to do that, or will someone else be doing that?
I'll have to do it. Just let me know when you need the next slide.
All right, let's go to slide number 2 then. And I'll just call out the numbers as we go here. But, good afternoon, Chair Domino and members of the commission. I just first of all want to thank you for the opportunity to share about our MDCE program and discuss the importance of including the American Academy of General Practice in addition to the ABMS pathway for board certification. As mentioned earlier, presenting with me today is Mr. Mark Lowe, who is the Executive Director of the AAGP, and Drs. Oksana Nesterenko and Caleb Chu, who are Associate Medical Officers for Pacific Medical. And you'll hear more from them later as we go through this presentation. Now, I currently have the privilege of serving our company, as I mentioned earlier, as the CEO and the CMO. But a little bit about my background, and that is I am a board certified family medicine physician who over the past 40 plus years have had the really the privilege of serving in every aspect of medicine, from academic to public and private practice and military medicine. I'm also an associate clinical professor at 2 university medical schools, and in the past, I was a past president for another university and medical school. So as a former member of our state legislature and a current member of the other board in our state that licenses physicians, the Osteopathic Medical Board, I clearly understand the significance and the importance of ensuring that the physicians we license in our state to care for our citizens are professional, they're competent to practice medicine, and at the end of the day, do no harm. Our goal with today's presentation is to share with you the significant importance of the MDCE program that we have put together, and ask for your support to include the AAGP board certification pathway as an additional means for physicians to completing their MDCE program to achieve board certification. So we're not asking for this pathway to be in lieu of, but to be in addition to. We could advance to slide number 3. So in 2021, as we all know, our state recognized the importance of closing that gap of our physician shortage with an untapped resource. And that was to create this alternative pathway for physicians who graduated from abroad from medical schools that were recognized by the United States as meeting the same academic standards as the schools we have here in our country. A year after that went into effect, Pacific Medical Specialty Group admitted its first 2 IMG physicians to the first MDCE program in our state. And then recognizing the significant importance of ensuring that our physicians were competent to practice safe medicine, a rigorous academic program was developed. As we did that, we kept the Washington Medical Commission informed as to how that program was being created, and following a parallel model to the primary care residencies that those of us who went through those residencies had, with 2 exceptions. We did not include OB and we did not include surgery because our focus was training primary care providers to meet the primary care needs, specifically in our underserved communities. So while ABMS, or the American Board of Medical Specialties, which has been the accrediting organization for residency since 1989, was considered to certify, we considered as a possibility to certify our program. At the time when this was started, it did not have the means by which it could address physicians training in an alternative pathway program. So we turned to the American Academy of General Practice, which did have the means to evaluate and ultimately certify this program. So over the past 4 years, we've continued to improve, to strengthen, and manage this program with the engagement of AAGP and keeping WMC abreast of what we were doing. The American Academy of General Practice has been with us lockstep all the way, looking at how we were developing that program. Although AAGP began shortly after ABMS, AAGP is the leading professional organization nationwide that supports the growth and recognition of general practice physicians here in the United States. And with that, I'm going to turn to Mark Lowe to talk about AAGP and how that fits into what we're trying to do here today. So, Mr. Lowe.
Thank you, Dr. Fleming. Well, as I've mentioned, I am the executive director of the American Academy of General Practice, have served in that role since 2019. And we are a professional association that has 3 main goals: to promote general practice, improve access to care, and to assist our physicians in professional development. As Dr. Fleming has stated, we are not an ABMS board. The ABMS is a recognized standard, and we support them. We don't view ourselves as a competitor, but we are in existence because ABMS boards do not offer a pathway for as many as 100,000 qualified physicians who don't, quote unquote, fit the mold. And so we offer a board certification process for general practice physicians that is readily attainable. And we really partner with several organizations already. One would be the University of California at San Diego. They have a program called the Physician Re-Entry and Retraining Program. And so we have some experience in partnering with qualified organizations. And so we are pleased to offer this board certification process to graduates of Dr. Fleming's program. And we'd be happy to entertain any questions that we could hopefully clarify.
Let's go to slide number 4, if we may. So as I had noted previously, you know, all of us here in Washington have for several years recognized the physician shortage, most notably in the primary care specialties and in the rural communities. And that's not to say that our urban areas are experiencing similar pressures, but the result has been felt in delays in care, which have impacted significantly on our underserved and our vulnerable populations. If we may go to slide number 5, please. So when we look at Pacific Medical in the MDCE program, what we have done over the past 4 years and will continue to evolve is a program that's beginning to fill those gaps by training physicians who the goal is that they will stay and practice where they are assigned. They'll lay down their roots, they'll raise their families, and they will continue to prosper in those areas. One of the things I'll point out is specific, actually I'll hold that off to the next few slides here, but we'll talk about the geographic footprint of this program and the significant importance that it plays. So Mark, you'd like to add to that?
Yes. Like I said, I've served in this role since 2019. And as everyone recalls, right after that is when we had the COVID crisis. And COVID taught us a lot of lessons, some good lessons and some very hard lessons. And a lesson we learned at the AAGP is that we have too many physicians in the United States who are on the bench. They have qualifications and abilities to help us, but for various reasons, they can't be brought into service. And we have found it a little bit ironic as we've thought through it that our country has done such a great job in developing and bringing mid-level providers, primarily nurse practitioners and physician's assistants, to address this crisis of shortage of primary care providers. But I think we've also learned that mid-level providers can address all the needs. One, there's not enough of them, and two, they don't have the scope of training to deal with a lot of primary care issues, and there aren't enough specialists to take referrals. So there's got to be a higher level of care by primary care physicians available so that everyone can work collaboratively to take care of people. So we would feel like if Washington State would approve our amalgamation with PMSC to provide a board certification process, that this could be a model for the rest of the country. And we would welcome that.
Thank you. We could go to slide number 6, please. Dr.
Good
Nestor,
afternoon.
Dr. Chu. Dr.
Yes.
Chu.
Thank you. I'm just going to speak briefly about the highlights of this program. The MDC program established is a highly structured and rigorous 4-year program with several layers of oversight. Physicians train under board certified mentors and undergo quarterly reviews. They engage in monthly CME sessions and journal clubs led by subject matter experts, and physicians undergo annual evaluations and examinations. They also maintain detailed case logbooks, which are reviewed internally and by the American Academy of General Practice, who has been involved with the program, as said before, since its inception. At the end of the program, physicians must receive a recommendation from the Chief Medical Officer before sitting for the AAGP board exam. This is a demanding program with a 4-year commitment, and not everyone completes it. The attrition rate hovers around 6% at this time. This program has been in operation for 4 years and is currently undergoing formal certification by the AAGP, and such a certification further strengthens the external oversight and accountability built into this training model. Next slide, please. I'll pass this over to Dr. Nestorenko.
Thank you, Dr. Chu. I would like to add that the physicians entering to the MDCE program are already highly trained and experienced physicians. They bring a diverse range of clinical backgrounds that strengthen Washington's physician workforce. All physicians graduated from internationally recognized medical schools and are ECFMG certified to enter our program, which ECFMG certification requires credential verification and passing the USMLE examinations.
I know.
Many of the physicians, as you can see on this slide, also completed residency or specialty training in their home countries before coming to the United States. 88% of the physicians in primary care specialties, 13% of the physicians in surgery, 4% in trauma surgery, 4% in mental health, psychiatric medicine, and 100% of the physicians in our program graduated from med schools that require at least 5.5 years of in-person training. Today, about 36% of the physicians in our program practice in rural communities where physician shortages are especially significant. Thank you.
Thank you, Dr. Nestorenko. If we could go to slide number 8, please. So one of the questions that often come up is how does one really ensure that what you say you're doing? And one of the ways we measure the effectiveness of the program is through what we call monthly QAPIs, or Quality Assurance Process Improvement Committee meetings, And those are held in every facility where a physician is placed to do their practice training there. Through that, we have demonstrated better patient outcomes with their presence there, improved patient satisfaction, but most importantly is the return to hospital rates, which is perhaps the most impressive statistic that we have there. The return to hospital rates in 100% of those facilities has been reduced with their presence. Yeah, Oksana, do you want to address the diversity piece here?
Thank you, Dr. Fleming. Yes, another strength of this program is cultural diversity. I spoke a little bit about the clinical background diversity, but cultural diversity is another important point. Our physicians come from many different countries, including Ethiopia, Sudan, India, Nepal, the Philippines, and Ukraine, and others. The diversity in physician workforce helps build trust and long-term connections with the patients from the different cultural and linguistic backgrounds, which ultimately we believe helps to reduce unnecessary hospitalizations by creating these long-term relationships. Thank you.
Thank you. We could go to slide number 9, please. So because of this program and through this program, you can see right now our physicians are managing, that are in the program, are managing over 2,100 patients per day in their programs. And they serve within 17 counties throughout Washington State, which comprises 44% of our total counties. Our placement of our providers stretches for as far west as Port Angeles, as far east as the Colville region, as far south as Sunnyside, and then all communities in between there. Our target is really at some of our most vulnerable populations, and the focus there is in post-acute and long-term care, managing patients from ages 40 to 104, I believe is our oldest, in the skilled nursing facilities, as well as in memory care facilities and assisted living. If we go to slides 10, I'm going to ask Dr. Chu if he will address that. One of the questions that sometimes comes up is with all the orientation that we are doing, checking the boxes of are the doctors getting exposure to U.S. healthcare system? Or are they getting training in the U.S. EMR systems and the ability to e-prescribe? And the answer is yes to all of those. But there's also a heavy focus on reentry into the fundamentals of primary care medicine. So we'll go through the next few slides fairly quickly, but they give you a sampling of some of those fundamental areas in the management of primary care within the various systems that we have. So Dr. Chu.
Thank you, Dr. Fleming. Just as Dr. Fleming said, we likely won't go through each slide individually, but these next slides truly simply illustrate the breadth of clinical medicine covered in the 4 years of the program. The program reviews the fundamentals of primary care medicine, focusing specifically on adult and geriatric populations that we care for mainly in the post-acute and long-term care settings. The emphasis is very much clinical and practice-based. So you can see the curriculum spans a wide range of major disease categories from neurological and cardiovascular conditions. Next slide, please. You can see it also includes pulmonary. And next slide. Endocrine and musculoskeletal disorders. Next slide. And also renal and mental health disorders. This is certainly not an exhaustive list and are merely examples of the disease states our physicians routinely manage and are trained on through education series, case discussions, examinations, and practice within the program. Next slide, please.
So the one thing I do want to emphasize, because oftentimes the questions also come up is, well, if they're working in primary care, do we engage the specialties that are within the regions? And the answer is absolute. There's consultation that takes place on a daily basis on the more complicated cases that require either specialty engagement or at least curbside consults managing these patients. Pacific Medical, as I mentioned earlier, covers a broad geographic area. It is currently the largest MDCE program in the state of Washington. By this summer, we will have over 30 physicians that are participating in, and our biggest concern with these physicians is that we are going to lose them as they graduate and complete their programs, because if we don't have that additional pathway through AAGP that we started with in the very beginning 4 years ago building, they won't be able to have that board certification and continue on in practice once they meet the other requirements for licensure. And I'm going to ask Dr. Nestorenko if she'll just touch base on some of the more acute issues that we have regarding that and why this is important. So, Dr. Nestorenko.
Thank you, Dr. Fleming. Yes, I would like to share briefly my personal perspective. I happen to help oversee the program and build the program, but also I'm humbled and lucky to be the first MDC physician practicing in Pacific Medical Specialty Group and one of the first few in the entire Washington state. Since 2022, like many physicians in the MDC program, I have invested years of my professional life in building my career here in Washington state and serving patients in our communities. Every day, physicians in this program provide care to more than 2,000 patients, and as Dr. Fleming mentioned before, across Washington state, many of them elderly and medically complex patients. We are very grateful for the work of the legislature and the Washington Medical Commission in creating a pathway towards a full licensure. Our hope is that the rulemaking process will also allow for a practical pathway to board certification, so physicians who train here can continue building their long-term careers and serving patients here in Washington. Our goal is simply to continue caring for communities where our patients depend on us most and in the state that we call our home. Thank you.
Thank you, Dr. Nestorenko. If we could go to the next slide, please, slide 15. So in closing, again, I just want to thank all of you and the members of the commission for your time, for allowing us to present today. We end with really two requests of the commission. First is to please consider Pacific Medical's MDCE program to continue as one of the model programs for our state here. We have a proven track record and a program with all of the safeguards in place to ensure that physicians are meeting the highest standards of performance through continuous feedback, annual evaluations, and culminating in a board certification examination process. This program has been, currently is, and will always be open to welcome the oversight from WMC as well as AAGP. The second request is to continue to include the AAGP as an additional pathway to the board certification process. Washington State, I just want to say as a sidebar, has always prided itself in being a state of inclusivity and not exclusivity. So as we began this process of certification and accreditation with AAGP 4 years ago, and has been one that's truly been one in the making, we don't want to lose this opportunity that we have. I don't know, Mark, if you want to add any closing comments, but after that, we certainly are open to any questions that the commission may have.
Well, I would just like to echo the appreciation that Dr. Fleming has expressed to the commission. We pledge that we will work very hard with all involved to make this affiliation one that we can all be proud of, and we would be very pleased to answer questions.
So, Dr. Domino, that concludes our presentation. So thank you.
Okay, thanks so much for the very interesting and informative presentation. I see some of the people on here, but I can't see everyone with the slide because half you guys are off the screen. But Mr. Matthews, I think you were first.
I'll defer to Ms. Blake.
Thanks, Micah. Good afternoon. Again, I'm Christine Blake. I'm a public member of the commission, and my background is actually healthcare administration. I just have a couple of questions for you. I remember in the past, now this has been in the it's been in kind of in the distant past, there was a movement made to have a different pathway besides board certification for physicians versus ABMS, and it didn't really move forward for whatever reasons. How are payers embracing this type of board certification? And also, are you basically just preparing these providers to work in your SNFs? Because I think you're mostly in skilled nursing facilities, correct? Or is this going to overlap into hospitals where the credentialing, they would have to agree that this is an accepted board certification through their bylaws if they were to bring a provider on with this kind of board certification? You have mentioned that California used it as a reentry program, which is different than bringing a provider on the medical staff.
Yes.
So those are some of the questions that I have.
Ms. Blake, I'll try to answer some of those. My other background is also in healthcare administration, having been a hospital administrator. But let me see if I can answer all your questions that you had. First, working in the was now a subspecialty area of primary care, post-acute long-term care, gives a provider what I call having their cake and eating it too, from the perspective is they get the full gamut of primary care rolled into one practice. The goal of and the commitment we made, excuse me, when we started this program was a realization that not everyone who trains in this program is going to stay with our medical group. Number one, it's just not possible to do that. So our goal was to train doctors at the highest level we could, and then it's up to the physician after that whether they want to go out and work in a private practice environment in a clinical setting, or whether they want to pursue other areas of interest that they may have in medicine. Our commitment to our doctors is for 4 years. After that, like I said, if they choose to leave, great. We now have a physician practicing in our community who is qualified to do so. Some doctors will stay, but we just don't have space to keep all those physicians for the long term. And it's recognized at the time they are accepted into the program that that's going to happen. With regards to hospitals and working as a hospitalist, the goal really of this program wasn't to train hospitalists. That's a different set of skills if you have. But if a physician wanted to apply for hospital privileges, I happen to serve as a chief of a department for one of our largest hospital systems here in Washington. And I also am the one who does the credentialing for the primary care docs within that system. What we look at is what the state law says. So if the state law says that this board certification is acceptable, then we amend our bylaws to accommodate that. Because again, you can't have bylaws that go against state law. As far as payers go, I can tell you that payers have no issue, and certainly Mr. Lowe can address it too, but payers have no issues with physicians that are boarded through AAGP. I know in my previous practice, we had physicians here in Washington who were board certified through AAGP and never had an issue with billing on any of those. So I don't know if I've answered your question, but I think I tried to get all 3 questions there.
Yes, thank you. I know I threw 3 of them at you, kind of pretty rapid fire, but yeah, thank you. You did.
Thank you, ma'am.
Okay.
Micah, you want to
Sure.
say something?
Yeah, so first, thank you all for your presentation and being willing to share the program. I know that there can always be some hesitation showing your inner workings to a public group. So I want to acknowledge that. The I want to give a little bit of a history and help the commissioners and attendees understand why we're looking at some of this. Number one, for the past 6 years, we've been in charge of facilitating a IMG work group that had a number of interested parties. And part of that was exactly what you asked, Ms. Blake, which is, if there is a board certification allowance for AAGP, who would recognize it? And we had members of hospitals and insurance groups there, and they all stated that the requirements that are put on them is to recognize board certification. It's not necessarily ABMS every single time. And so that was our first inkling that, okay, there could be another option. The other option is, while I want to acknowledge that ABMS is making efforts in this area to allow pathways for international medical graduates, they don't actually have a pathway yet. Not one that's truly accessible. The closest that they have at this point is a American Board of Radiology, where you go and you match into a residency, and every other year is accredited by that board as far as the residency is concerned. So you become board eligible by going through that. That's not quite the same thing, and it doesn't truly meet the need of what we're dealing with here. Finally, we've got a bill that is just waiting on concurrence before it goes to the governor's desk that will bring this area into focus. And so while, again, I'm very hopeful by what I'm being told by ABMS, specifically the American Board of Internal Medicine and the American Board of Family Medicine, they're just not there yet with respect to the pathway, whereas AAGP is. The bill would create a pilot program, which would allow folks that are in groups like Pacific Medical Specialties Group to have a period of supervised practice that will then allow them to, with certain conditions being met, and that includes putting things into rule for the commission, to matriculate into what's called a primary care license. Non-supervised, they will have had 4 years of supervision minimum after that, before that point. And the goal is that they come out with all sorts of recommendations, as well as the equity side of things, a board certification that is recognized. So we're not, in the draft language in the rule before you, we're not proposing replacing ABMS. The language is actually crafted that if there is not an ABMS option available, then they can go towards AAGP. And in these cases, especially right now, that's what we're dealing with. So with all that exposition, I want to put the question to Mr. Lowe. Could you speak to the process of how board certification with AAGP works? Everything from, what are the qualifications to get there? What is the exam, and are there retesting requirements or anything like that, please?
Yes, thank you. Well, we have a pretty extensive process. There's 2 pathways to become eligible. One pathway would be to complete an approved residency program, and that's the most direct pathway. But many of our members, because of life events and various other reasons, have not completed a residency, and we have a second pathway that they may qualify for. We check their background. We check the National Practitioner Data Bank to look at any licensing issues or malpractice history. We, check their DEA number, verify their training, those type things. And so if they meet our requirements, our board votes on them on a monthly basis. And certainly we don't accept all applications. I don't have exact numbers, but I think probably 10 to 15% of our applications I would estimate are not deemed to be acceptable for membership. So as far as our board certification process, once someone becomes a member of our organization, they are deemed board eligible. And so that qualifies them to go into our board certification process if they desire. It's two parts, and the first part is we have an extensive education requirement through an organization called Audio Digest Family Medicine. And I think it's something like 82 modules. That may not be the exact number because it changes depending on how many hours each study or lecture would be, but it's a self-study type thing. It's fairly extensive. And once they complete that, and it's, reviewed by our board, they go on to the second part of our process, and that's where we examine 10 case studies where they present essentially 10 patient cases in writing, and our board will sometimes choose to contact them to discuss that orally and ask questions. Sometimes they won't. And then assuming they have completed those two components successfully, they are deemed to be board certified. We currently do not have a recertification requirement. What we do have is a requirement to maintain a certain level of continuing education and also certify each year that they've had no malpractice actions or conviction of a felony or several other things. So it's kind of a self-certification on that. And I'm not sure if I answered all of your components of the question, but if I didn't, please let me know what I missed.
No, I think you got it. And so follow on, and this is just, I think this is my understanding of sort of the background here to Dr. Fleming. If you could, in our conversations, you've discussed that the program that Pacific Medical Specialties Group has adopted has largely been influenced by, for lack of a better term, a layout or a rubric that AAGP aligns with their board certification process. Is it possible for you to sort of illuminate on that a little bit as far as those requirements and where they came from?
Certainly. So when we started building this program, one of the big pieces that was a requirement or prerequisite is that we built a very stringent and robust academic piece to the program. And that's what we have presented to you today, which over the 4 years, once the physician has completed that program, they have successfully completed their annual examinations. They are then recommended to AAGP for consideration for board certification. The one thing that, Mark, I didn't hear mentioned was, I thought in the beginning there was a conversation after they had met those requirements you have mentioned, that there was a written examination that they took to complete their board certification going through this pathway that we have. So, Mike, I'm not sure if I've answered the question, but that's how we aligned the program and set it up originally, was to ensure that building safeguards as well as an academic component that was a fairly stringent one that had measurable outcomes to it.
Yes, thank you.
Jeb, you have an answer? Sorry, before. Is there another comment relating to that same item? Yeah.
No, just a new question, if I may, Dr. Domino.
Sure.
Great. Hi, everyone. My name is Jeb Shepard. I'm the Director of Policy at the State Medical Association. Thank you for this presentation. Learned a lot about a group that we're less familiar with. So just at the top, the Medical Association supports incorporating IMGs into our healthcare workforce in the state. At the same time, we believe that pathways to licensure for IMGs should uphold appropriate education, training, and competency standards that protect patient safety. And so sort of looking at that section of the rule through that lens, we've worked with a smaller group of physicians involved in medical education and training. And the concerns we shared with the medical commission is that the ABGP does not appear to maintain the same eligibility, education, training, or assessment that are comparable to ABMS. And so, like I said, we're still learning about your group. And so curious if you have any sort of document or resources you can share that compares and contrasts those elements. I think it was mentioned that there's a track without a residency. And I think that would be of interest to our leadership as we try to understand what's being proposed by the medical commission.
Yes, we can certainly provide information on our two pathways to join our organization, and so we can send you information on that. We don't have anything available that compares and contrasts us to the ABMS program, simply because we don't completely understand that program. You know, we're certainly going to be different than that program because we have to be. This is an alternative pathway, and it's certainly not going to meet ABMS standards kind of by definition, or we'd be like them, and there wouldn't be a need for our pathway. So I know that's a little talking around the issue, but we'd be more than happy to send you our two pathways.
Great, thank you.
Well, I just had a
Dr.
question
Fleming.
about it working in a residency program. You know, they get evaluated on a lot of different scales, and they get a monthly evaluation. And in a lot of cases, in my specialty, which is not primary care, they get a daily evaluation. Do you have that sort of similar thing, you know, in terms, I mean, because they do have meetings to discuss cases, but, you know, are you looking at their professionalism as an example? I assume so, because you'd hear something, but do you have people who are there who are observing it, as opposed to looking at it from far away, where you often, everyone can pretty much become professional if they know they're under observation, as an example. So all those things, I forget what the ACGME requirements that we have to rate every month, or as I say, more frequently. Do you have that in your program?
If I may answer that, and then if I may also
Sure.
circle to Jeff's concerns that he had. But the answer to your question in short is yes. So there are several things that takes place on a monthly basis. One is the face-to-face feedback that the physicians are receiving. The second piece to that is the auditing part. And we have a separate group of physicians that are board certified that audit the performance as well as the charts of the providers every month. And through that process, there's also feedback given. And I can tell you, I know off the top of my head, there was one physician in particular that despite multiple feedbacks and reviews, didn't make it and was dropped from the program. So that feedback loop is built into there on a monthly basis. I appreciate the concerns that Jeff raised, and as a former member of WSMA, I recall back when I was involved with that organization, we had an academic committee. I don't know if it's still there or not. That used to look at programs across the state and provide comments and feedback. But if that committee is still there, I certainly would welcome engaging them as part of that, for lack of a better word, oversight, but engaging them to ensure that whatever those fears that are there are allayed. You know, having, like I said, worked, taught in medical schools, worked in residency programs, set up residency programs, the ABMS pathways that we have there, you can't get to identical programs. And the reason why you can't get there is in a family medicine, for example, we have that hospital piece where you're doing rotations there, especially if you're in a program like a community clinic, family medicine residency these days. They're going to have a one pathway that, or not pathway, but rotation that's going to be hospital based. They're going to have some exposure to surgeries. They're going to have exposures to obstetrics. Those are those are experiences that we are not training doctors to do. If they have that desire to do that, the door is always open for docs to either apply to a residency program and matriculate, over to that if they really have that burning desire for that. The goal of this program, as it was stated earlier, is really to train primary care providers in a primary care outpatient setting. But the concerns are these docs really, and I heard this during the testimony also. No, these docs are underqualified. They don't have the same training we have, and et cetera, et cetera. I really want to allay those fears, because I will tell you, when I took the first 2 doctors into this program, I was as skeptical as you could get. I had my doubts that these doctors could make it. And much to my personal surprise, these physicians are intensely focused on performing at the highest level and doing their best. I would put my life in the hands of any of these physicians that are in this program at any time. So I really want to allay that fear that you may have there, or that concern, and would welcome, more engagement on that as time goes on with this program. So thank you for that.
So one of the, just had another question, and that had to deal with the fact that some of these people may be fairly isolated, or they may be moving, of course, to areas like rural areas where they may be very different from where they trained in their home area. And how are you helping both, number one, support them and help them learn how to become American in those areas? I mean, it's like, I feel different when I go to certain parts of the state, as an example. How do you make them learn and feel comfortable in that area so that they integrate into the system, the whole society, in the places that they're working in that?
That is a great question. And I will tell you, in the rural communities where our physicians are placed, there's 2 things that take place. One is their ability to integrate into that community. And so they're learning a whole new set of values and expectations of what it's like to be in that rural community. The other piece is are they getting that clinical experience that they need to have? So not only are they getting it in the setting, but they also have the mentorship. So I'll pick on Dr. Nestorenko as an example, and myself. And then we have a few other doctors, Doctors Min and forgot the other one. But these docs are also out in the field, meeting with these physicians on a monthly, if not weekly basis. I know in some cases we meet with the doctors every day for several weeks, and then we let them solo for a little bit, and then we come back and provide more follow-up with those physicians to ensure that they're getting that. In addition to that, as Dr. Chu pointed out earlier, there's a monthly requirement for participation in which either the physicians meet in person or they meet by Zoom, and they go through a clinical program focused on either a specific topic pertinent to the practices that they're in, or an area of clinical medicine that is felt that they need to put tools in their toolbox for. So, the idea that a physician is placed into a rural community and then they're out there on their own and they're never seen again, it just doesn't happen in this model. Did that answer your question, Dr. Domino?
Yeah, pretty much. I mean, I think you have a good program there. I was just trying to think of other things besides maybe that are, community involvement, training by the nurses,
Yeah.
the aides, the people who see who they work with, right? The
Yeah.
person who's cleaning the floor is very important to be able to understand, because these are going to be your patients and how you relate to people in that area.
You know,
So,
you know, it's really an interesting thing that you mentioned there. The cultural integration is really fascinating. You know, in the areas where we've placed rural doctors, I've always had a fear that, you know, they're going to get there and they're going to see. I'm a country boy, so it doesn't bother me. But for some people to get out in the country where you don't have a lot of stimulation, electronic kind of stimulation, you worry about that. But every time I've gone into one of the facilities where we place a doc, the staff there tells me, this is our doc. We love him. We never want him to leave here. You know, we ask the doc how they're doing. They love their communities. They never want to leave there. It really has surprised me in a very pleasant way that that's happened. And what we do, what I didn't mention, when the physician is selected to come into the program, a couple of things take place long before they get there. In the screening process, the evaluation team looks at a doc's ability to work either in an urban setting or a rural setting. They are, for lack of a better word, grilled on what the expectations are if they go into those communities, and are they willing to do so, and or are they able to do so. And that committee that does that screening does to date, I will say, has done a phenomenal job in matching the right physician to the right facility. I don't know how they do it, but it has worked extremely well so far, and I'll knock on wood for that.
thank you. Micah, I see your hand raised.
Thanks. Just a couple of things just as far as reminders for the commission. So with respect to periodic evaluations, about 2 years ago, you adopted what we affectionately call the CAE, or the Clinical Assessment Evaluation. That is something that's based off of the entrustment scale. It was developed by in large part by Dr. Judith Powles, who has a long history with family medicine residencies in Washington State. And so that's something that we do ask the supervising physicians to do periodically and I think in the language in the actual document itself, it says quarterly, but they can do it more often. And the expectation of the IMG work group in that was that it would not take longer than 18 months to go from a 1 to a 5 in all of those entrustment scale categories. The second thing that got brought up a little bit earlier was respect to setting and location. And I did want to let folks know, without naming the specific facilities, but there is an effort underway to develop a hospitalist solution using these clinical experience licensees. And it's being viewed not only as a shortage solution, but possibly to some degree a cost solution. And these are areas where after a certain point in the night, there just isn't a physician on site at all. And so addressing those shortage issues is a major goal of that. The idea being that if these particular hospitals are able to come up with a program that is defensible and able to be replicated, then they would be able to port it out to the other hospitals that are in need in that way. Thank you.
Thanks, Dr. Chang.
Yeah, so basically, being a retired family physician or family physicians, I certainly welcome, any, kind of pathway trying to build to increase the primary care physician, supply. Just forgive my ignorance on this question. The first question is to Dr. Fleming. So regarding your MD-CE program, is this, trying to understand, is this like a residency program sort of as a setup? And if so, do those physicians coming to your program, do they get a stipend through you, or the placement where they go to, they pay for their to go there, or do these physicians, the IMG physician applying to your program, they pay you just to complete the program? And then secondly, just a comment to Mr. Lowe. I came at times when, we're talking about all the medical boards are talking about recertification. I think recertification being in the family physician, American Board of Family Physicians, it's already have some kind of research process, but then they started kind of trying to standardize the recertification process. And I basically have several colleagues that got upset with that, and they decided that's when I first heard about AAGP, because they did precisely the difference, and they talk about that they don't have to go through a recertification process, and it's an alternative way to do it. To me, I was kind of surprised, because I thought it was kind of building as the generals that everybody has to go through recertification, and that's how we kind of keep abreast with the knowledge. And so, that's just my comment. I'm not sure if that can generate some thoughts on that. So.
Well, let me comment just on that about the recertification process. But we are open to having a recertification at some point, but at this point we don't. But that's not to say it will never change. So we do have an open mind about that, and I certainly agree with a lot of the points you made.
So, Dr. Chang, if I can address the questions that you had, and I'll say as a sidebar, because I know we get hung up on recertification examinations. I went through an ABMS program. Mine was the last class, however, that got grandfathered to where we didn't have to do recertification, but we're recertified by maintaining our CMEs, just as a sidebar to that. But with regards to the program, because we can't actually call it a quote residency program, we have tried to build the program in what I would call a look-alike program to a residency. If you look at family medicine or internal medicine, the residencies are 3 years. This is 4 years. But a lot of the feedback loops and check marks, if you will, on are the physicians getting the actual clinical exposure and training that they need, it would mimic a residency program pretty close. With regards to pay, we do not accept payment for this program. We recognize the physicians as being somewhere between a full-fledged practicing physician and a resident because of the years of experience they bring to the table before they even come into the program. So they are paid a stipend, but it's above what a resident stipend would be, but below what a full board certified practicing physician would be. Does that answer your question?
Yes, thank you.
Thank you, sir.
Are there any other questions or comments?
But just like
Seeing
to
none, is there
thank
someone
Dr.
else?
Fleming for his offer to connect with the medical association. We don't have the academic committee anymore, but I can connect with our leadership to see if more education and discussion might be something that'd be interested in.
Sure. I'd be happy to work with them on that.
Great.
Thank you, Jeff. I have one question, Jeff, if I might. Did your position replace Lynn Edinger?
My colleague Sean Graham's position replaced Len.
Okay. We had long history over there at WSMA with Lynn.
That's right.
All right. Well, last call for any other comments or so. And seeing none that I can see, the next item on the agenda is the discussion of the draft language. We will begin where we left off in the first workshop at WAC 246-919-445 on page 35 of the materials. If you have a comment, a question, or suggested language as we work through the draft, please use the raise hand function with the Teams platform, and we will call on you as soon as possible. Amelia, would you like me to go on or just read this whole paragraph? Or stop there?
Let me pull up the script. I don't remember what it
Yeah.
says right now.
Well, there's no break there, but it does seem that we should start there and then move to where the following thing is where is a new topic.
So go ahead and read the rest of that paragraph because it's important for later.
If we reach the proposed new section, 246-919-604, called Physicians Providing Advanced Procedure Support to Optometrists, we will not be discussing it today. That will be the focus of our section at the next workshop, as we've received many comments related to the proposed language. Those comments are included in today's materials. At around 2:45, so that looks like 32 minutes, we will pause the discussion to review next steps and dates for future workshops.
Thank you. Okay, so as Dr. Domino mentioned, we are going to start with section 445, which is about health equity continuing medical education training requirements. We've had a suggestion to change the title of this section to cultural safety continuing medical education requirements. And then there are just some comments. So this section was created based on a statute, which is RCW 43.70.613, which is all about health equity continuing education. And within that RCW, that statute, there is no direction to make it all about cultural safety. So my feeling is that we wouldn't be able to require cultural safety for the whole 2 hours. I think because it only states that the topics can include cultural safety, but are not limited to that subject. So I think we can say, since the 2 hours is what's required, we can say that an hour of that should be about cultural safety. I think we can require that piece. I don't think we can change the name of this section because all health professionals have to take the same sort of education. So that's just my comments about the changes that have been proposed to this section. So you would just need to discuss whether you want to change the name. Again, I don't think that we can, so. Okay,
Well, if we
Mike is
can't
saying,
change the name, then why even discuss it?
so Micah did say in the comments he would recommend withdrawing the changes based on the comments, so.
I agree with that.
Okay,
Agree.
so we will say no to these changes. I think those are the only ones. Okay. And then I'll just make a note here that this was approved. Okay. So then we have the next section, which is 460, which is about categories of creditable continuing medical education activities. And it just talks about the categories that are available. There are some changes that have been suggested. And then there's this first one where there's a suggestion to change this language here. And then Micah does point out that there's a comment that we received that this is responding to. And then WISMA did suggest that we change this language to recognized accreditor instead of providing organization.
Is Jeb still on? Because we've in practice, I've seen it written both ways, so I wasn't sure what the suggestion was from WISMA as far as why one over the other.
He is.
Yeah, that was the recommendation of our CME lead at the Medical Association. Her recommendation was to avoid confusion. and aligned with recognized accrediting organizations.
But that's what my thought was, Micah. I think that probably too, for recognition of accredited organizations.
So instead of providing organizations, it would be accreditor.
Mm-hmm.
That's a suggestion.
Accredited organization, yeah. Or creditor organization, yeah. I'm okay with that.
I'm fine with it.
Yeah, I'm fine with it.
I can spell it a. Oh, is it fine to leave organizations?
Yeah,
I'll
I think
remove
so.
it.
What was
Okay.
that?
Is it fine to leave the
so.
word organizations was my question.
Mm-hmm.
I wonder if instead of saying recognized accreditor organizations, we say recognized accrediting organizations.
Yes. Yeah, I like that word.
That's
I like
better.
that word better. Thanks, Micah. I was pondering that myself.
I'm channeling my inner Stephanie Mason, with my English and red pen.
Okay, so we're good with that change and adding American Medical Association, those things that have been suggested. Thank you, Dr. Chu. Okay. So moving on to subsection 2. So there's been this additional language. Hopefully I can fit this all on the screen. So this is for category 2, adding acting as a physician reviewer on regulatory cases, serving as a clinical expert witness, or participating in peer reviews at recognized healthcare institutions may be claimed on an hour-for-hour basis as category 2, if not accredited as category 1, excuse me. And then Micah has a note here that this is a long-standing request from commissioners and other boards that we allow this for expert witnesses. And then that peer review just makes sense as it's the same vein.
Yeah, very long-standing from commissioners, if I'm being honest. And then as far as the expert witness piece goes, that is actually standard in California and Arizona. It does seem to be going that way as far as you're able to claim category credit for your work and time reviewing peer review work or expert witness.
I just,
oh, go ahead.
Well, I don't know, I mean, I give lectures and I spend hours preparing and I can't even get credit for giving the lecture for CME. I mean, to me, it's just part of if you're going to review these things, first of all, if you're doing medical malpractice, you get paid very well. Sure, you have to look up things, but a lot of that is sort of independent study kind of review, and how many hours you actually put in. I don't know.
Well, I will point out that your example of preparing a presentation would actually fall under one of our other categories, I believe. It
would, but
yeah,
maybe
category 3 is the first one.
Yeah, I'm just saying I know people learn in different ways and it does take time, but some of it is extra time that might be more time than the learning occurs, meaning trying to perfect your language and your arguments. But I don't care. I mean,
I actually can support the category 2 adding that part. Just kind of just thinking how much time we do, like a lot of time to review that. Even that, just having that may potentially attract people who are still practicing, that they say, yeah, their time's worth it. So.
So do we want to accept this change?
I do.
Yeah, I'm fine with it. Dr. Domino.
I won't vote. I mean, I would never do this and get CME credit for that. So I guess maybe some people would, but I'm not sure. Reviewing a case, and please don't put CMT. I mean, we do a lot of lookup of things for that, but a lot of the case review is sort of on what you know, because you get case review in your areas, or anyway, it's fine,
But there is an upper limit, like how many hours you can claim for is 80 hours. So it's not entire things that you claim for it, all your CMEs and stuff like that with this.
Yeah, 80 is a lot. I mean, if you're claiming when you're writing, I don't know, I write papers. I don't ever claim CME, right? I mean, there are a lot of activities we do, but this would allow people, I think, who don't have, to do it. If it's popular, as I say, you guys can vote for it, and I'll just not vote.
So we're going to do accepted by majority, since there was two.
Yeah.
Okay. Okay. So we got that change. I'm not sure why this was. Clean that up later. Okay, Micah.
Right.
You have a note here about prior authorization or utilization review.
Right. So in looking at this particular one, it's talking about quality care or utilization review. It didn't expressly say prior authorization review work. So it seemed to imply that that's what it was. And then I did explicitly move, quality care stuff like peer review up to category 2. Like I said, I think that if we're going to give credit, we should certainly incentivize that more than, prior auth claims.
Okay. Commissioners, are you okay with this change?
Yeah, I mean, it's just that being on a lot of quality improvement committees through my career, also, again, these are just service activities. You learn a lot from it, and being responsible, designing your quality improvement system in your department, and everything takes a lot of effort. I think having prior authorization and utilization review to me is more financially driven. So I'm happy to move quality up.
Do we have to say for both, prior authorization or utilization? I mean, certainly I practice in a Kaiser system. To me, it's just simply just utilization. So we don't submit for to other insurance for prior authorization. So to me, that's kind of foreign to me. But I thought that meant pretty similar. So I thought utilization is just utilization.
To my knowledge, and I'm happy to be corrected on this, prior authorization is obviously, the first part, and really this is being directed at those clinicians that are in charge of reviewing that and saying yes or no. Utilization review, in my experience, is the back end after the service has been delivered, and they say, is this being done properly or not? So to me, they're two different functions. I'm not in the drafting. I was not intending that the physician that's submitting for prior authorization be the one able to claim it. It's more the reviewer.
So then include both prior authorization and utilization review?
Well, if they're different, I thought
They are
do
different,
we
yeah.
do prior authorization and utilization review? Call say both are accepted rather than using or.
I'm having a hard time reading it because of the different color, and it's kind of small,
Sorry.
but that's
Oh,
okay. But
hold on, let me fix that.
okay. So they are two different things. Prior auth, and then later, and then down the road, UR looks at it. So can you just Oh, thank you. Can you just remind me again of what we're adding here? It gets to move quality up to category 2
Mhm.
and incentivize that more.
And replace
So-
it with prior authorization under category 5.
I'm okay with it if everybody else is.
So then do you want to keep it or do you want to make it and?
I'd want to defer to a lawyer just to make sure that
Mm-hmm.
we wouldn't somehow be tying them to both.
Yeah,
Yeah.
because I'm wondering it has to be /and/or.
Calling on
we-
Luke.
Yeah, Luke. We can't
Yeah.
use and or, I will say that.
Oh, okay, I
Good
see.
show though.
Yeah, and/or is not. That's frowned upon. So, well, let's see, and I think the and/or would be disjunctive, right? So I want to make sure we're looking at sub E, prior authorization, correct?
Mhm.
Correct.
And/or. I think the prior authorization or utilization review, I think that would work. I'm happy to bring it back to Heather as well, just to make sure, but that'd be my take.
Thank you.
Okay, so we're good with prior authorization or utilization review, and then this other change to take out quality of care, replace with prior authorization.
Sure.
Got one yes. Dr. Domino says yes. Okay.
There was a thumbs
Yeah.
up in there somewhere.
Okay. All right. So this was approved. Let me make a little note. Okay. Moving right along to expired license. There were some questions about this section. So we had a question from Frida, who is our director of investigations, and she's asking if we would still have jurisdiction based on this change, even after the license is surrendered back to the commission. And then Micah had responded and said, my read is there's no license or property right. We would likely need to have a canceled status added to our SOPs. I don't know if that question has been answered since this was added, which was a while back. Micah,
Sure.
do
And
you have
just,
any?
yeah, so just to illustrate the issue here, with panel L, you see folks coming back who are trying to reactivate after more than 3 years. The basics of regulatory theory speak to issuing a license and then doing some sort of periodic renewal to make sure that there's still competence. And some of the assumptions along with that are that you don't automatically get to renew. And that there's some checks and balances in place that would be looking at, did you maintain your skills? So CME every 4 years is one of those things. Some states have a questionnaire where you have to self-declare that nothing has changed. You haven't been arrested or anything like that in between those times. And I think Kyle's going to jump in here in a minute. So the question that we've wrestled with is what exactly is our explicit authority when someone has been out of practice for more than 3 years? Do we need to create more of a structure on how we respond to that, or is it just let them pass go if they pay their late fee? Kyle?
You're muted if you're talking, Kyle.
Yeah, sorry, this is
Okay.
taking even longer than usual. Karen, I think I'm having the same problem you did at the beginning. So this is all, I mean, I've talked to Heather about this issue a handful of occasions over the years, and I'd certainly invite comments from Luke if he has thoughts. The idea behind this is that they're an expired, for the benefit of the commission members, expired is a license status. It doesn't mean you have to have both a license, and the license has to be active in order to practice medicine in Washington. And as Micah was saying, we've dealt with numerous occasions where folks have let their license expire and then come back to Washington with no kind of proof of intervening practice. So it wasn't like they were practicing in another state, they didn't need the license here, but they were still actively practicing. And so we've talked about that scenario on numerous occasions. It does come up, as Ms. Blake will tell you, in panel L from time to time. Looking at this for, I think, the fourth time, I would just maybe have a slight suggestion in the language. And we might say something like, instead of reissuance of the license is not automatic and may be subject to denial, we should probably add something there saying maybe subject to conditions, including denial. Because most of the time, I think what panel L is looking for is something indicating that the physician's ready to go, right? And that their skills aren't so rusty that they're going to be present somebody who's practicing in a substandard way. Does that make sense?
Yep.
So forgive my kind of ignorance about kind of reapplying. When they reapply after they that their license lapse, do they get the same MD number? The license number back, rather than say getting a brand new license. I think that's probably a difference because before I had the Oregon license too, having had both Oregon and Washington license, I know Oregon does differently. Once you say you retire, if you actually elevate to say you return license, and they say should I return back to practice, I have to reapply to get a new license number, which is different than the issue you're talking about here. So, and it goes through the same process as I'm a brand new physician going through the process.
We don't really have that system in place, Dr. Chang. And the statutes in this particular area are generally silent. They don't really talk about this in any length. And for the most part, we rely on the department's rules around this issue. It's part of 246.11, which is not something that we're dealing with here. But I think what the hope is that we can carve out some sort of notice to potential licensees that if you do lapse for past the period of time where it's kind of automatic, we're putting you on notice that we may have some questions for you and may impose some conditions when you come back to us.
This also jump in really quickly.
Sorry, go ahead.
Or Micah? Yeah, sorry.
No, go ahead.
Yeah, so I think that including those conditions does help sort of further the overall purpose of the Department of Health, right? Like ensuring safe practice, making sure that the public is safe. So I think in terms of policy wise, it's, a good idea. My one question was though about some of the terms, because it seems like there's quite a few terms that are used around. It says like a license that has lapsed or remained expired. And then at the last sentence it says a physician seeking a licensure after such a lapse. So there's kind of a lot of terms that are maybe not immediately clear to me. So example, you're saying it's lapsed or remain expired, now it's surrendered, but then, reassurance of this license, seeking licensure after such a lapse. You might want to say seeking licensure after the license has been deemed surrendered. So that way you're a little bit more consistent. I think in terms of that phrase, reissuance of a license is not automatic. If the purpose of that is to provide notice to folks and kind of, trigger people to think, oh, this isn't automatically going to get back, it does that. However, the fact that it goes on to say that may be subject to conditions, I think that implies that it's not just automatic. So legally speaking, it may not be necessary, but it may sort of provide notice. And then otherwise, I'm not sure if it might be a little bit more clear if reissuance of the license is sort of a new subsection, because you're talking about how it's expired, and then the new subject is like, if it is expired, here's how you could get it back. So stylistically, I might consider breaking that up.
In 2A, it actually speaks to that a bit.
Sorry, it speaks to
You mentioned about their reapplication process, and so that's speaking to some of that.
Sure. Sorry, I wasn't clear. What I meant was breaking up the two sentences.
Yeah.
A license that's lapsed or remained expired for more than 3 years is deemed surrendered to the commission. Then new topic, reissuance of that license that was deemed surrendered isn't automatic and is subject to conditions. That's what I was referring to.
Yeah.
Okay, yeah.
But that makes sense. I like that.
But those are my thoughts. I mean, of course, defer to Heather. She's the subject matter expertise, or subject matter expert, I should say. But yeah.
Okay, so I think we're taking out lapsed and just leaving it remained expired for more than 3 years is deemed surrendered to the commission, correct? And then,
Well, before we move on, we
okay.
probably need to address Mike Farrell's comment.
Okay, what's this?
Because it's specific to surrender.
Oh,
That's true. Oh, well.
Oh, don't use the word lapse. Okay.
Which we're trying to, we just did that. We just took it out.
Yeah.
Considered surrendered. Oh, I see. Hmm. So this needs a rework if we, okay. All right, so I think.
Let's put this off this time, Amelia.
Yeah.
And come back to it, please.
Mm-hmm.
Yeah, I'll come back. I'll rework this based on this conversation and rework it for the future. Okay. Then we're moving right along. Okay. Okay, so this particular section, this 480, which was retired license. So first off, I don't think that we can use this slash in rule. I know we can't use this slash in rule. We can say or. And then we would need to define what emeritus is in the definition section. So this needs some more work too. Okay, this is just a note for me to remember. So I may defer this section too because I need to do some reworking. I just want like right now to hear thoughts from commissioners and others about the emeritus piece of this. How can I ask what is the difference between retired and emeritus? Like what exactly are we trying to say when we say emeritus?
I don't know if it's the same thing as it would be, say, in a facility setting, but emeritus is fully retired provider. They're not going to work anymore. It's more of an honorable title than it is a retired provider who might, say, do some volunteer work or something somewhere. But that's just, how I have seen these definitions.
Yeah, that's my understanding. Emeritus is more like honorific term, usually either in a medical group or academic setting. They give that. It doesn't speak to whether they're still active or inactive. And certainly in the academic setting, emeritus professor can still come back and teach from time to time, but it just means that there's a title that they give that they honor them, being retired.
Right.
Well, also like in clinical departments like mine, to not be that track, you can, if you've been through a professorial track, you have to retire even if you come into work and do non-clinical work and even clinical work below a certain level, which is less than 40 hours a week. So they still may be working. They use the word active and inactive a lot.
Yeah.
Because inactive, and not everyone gets an emeritus. It'd be more of
Right.
an honor. I mean,
Right.
it is, but emeritus professor in my department are all doing stuff and
Mhm.
working, and often on, and it's still on the payroll largely.
I guess it kind of depends on how that emeritus is used in various places, whether
Yeah.
it's
I
a title
know.
Yeah,
given
so
to
why
a
do we even
provider
have an
for,
emeritus license?
yeah.
Well,
I mean,
I
it's-
know in Oregon State, they actually have emeritus title, but only applies to if the Oregon physician retire in Oregon State. Whereas it's that, like myself, being a Washington physician, having the Oregon license, I had to surrender my license, but not getting the emeritus, status, for that part. And what's the difference? I'm sorry, don't know if they say it's only uniquely for their state, physician. Versus the one we use, I'm currently in the retired active status, so I can volunteer. And that's something new to me. I'm just, say, oh yeah, I can still, volunteer, even though I declare being retired versus a retired inactive license. So, there's that difference there. So.
Are you looking at emeritus maybe as, are we, I guess, looking at emeritus as more of a, you had a license, but you're not going to practice anymore, or as a retired definition versus what we're seeing in different hospital settings?
It's a little bit of both. So obviously, my rule construction and drafting is nothing compared to Amelia's. But so there's a couple of things informing this. One, just historically, we've had people ask, do you have some sort of license like that? And we usually refer them to the retired. And I'll say retired only because there's like 4 different flavors of retired. And this is where the personal experience came in. Some of you may or may not be aware, my father's a retired physician. And when he went to go to get his retired status, he called me thoroughly confused. And I was like, it's not hard, just get a retired license. And then he's like, well, which one? And then I went and did research, and I had no idea why we had retired active, inactive, in-state, out-of-state. And then they actually have different requirements, which is thoroughly confusing to me. So this is the start of trying to clean that up. The goal here is that what I'm proposing is just have a retired license. It doesn't need to say active. It doesn't need to say inactive. That's something that facilities can deal with. And in my mind, retired and emeritus is it's the same thing, as far as the license type. But if it's causing confusion, happy to walk away from that. And I will just say that, my thought process in drafting rule proposed changes is just bring ideas for you all to consider, and you're free to say yes or no if it makes sense or not.
Sure. No, I get it. I was trying to take off the hospital admin hat and put on the commission hat and say, what are we trying to achieve here with this one?
Clarity and
Micah,
simplicity.
And Micah, you're right. That what changing transition to retired, status, and us reading and rereading is that which category do I have to choose, to fit what I need, and there's some confusing before I figure out, what I need to do. So,
yeah, I know that licensing gets a lot of this.
Folks, I know we're at the 2:45 mark, which I think there was something on the script. However, really quickly, I wanted to say there is a separate statute. It's 18-132-50 that allows for the creation of the retired active license status, which is, I'm sure, what's been relied on for rules. However, I'm not sure about, at least in my experience, I haven't seen whether or not there is any other sort of quasi-retired active license that's styled as sort of an emeritus. So it might be worth making sure, running that by Heather, just saying, hey, if we do this, are we running afoul of those, do we have statutory authority? Is this coming close to sort of creating a new type of credential that goes beyond the commission's authority? I don't, know the answers to that, but possibly one thing to flag with her if you haven't already done so. And if you have already talked about that, then please disregard.
I'm not sure we've addressed that specific issue, but I will point out a couple of things. So what you're talking about is it grants the commission the authority to create a status as opposed to a license. And that is, I would say, unfortunate drafting. It's created because the reality is this: in our licensing database, I think the new one, but at least the old one, there was about 40 different statuses. Everything from pending to closed to military, you name it. And I would say 95% of those do not have statutory authorization. So I think the argument is we can create a status that we want. It's creating a new license that requires the statute.
Mm-hmm.
I know in Oregon that when they do the emeritus status, they told me the difference is that, if for emeritus status, if they decide to come back to practice down the road, they go back to the same medical license number. They don't need to go through the, say, trying to be reapplying as a new physician versus myself, if I want to decide to move to Oregon and later on trying to reapply. I get a new medical license number, but not as a new physician, but not as a, say somebody coming out of retirement.
Gotcha.
Okay, so this will get a little bit of a rework, and then we'll bring it back later. So yeah, we are at that point
At the
where
time.
we
Yes.
should probably
Okay,
definitely.
well, we will stop here for now. Thank you all for your participation. Ms. Boyd will now outline the next steps and schedules for upcoming workshops.
Okay, thank you, Dr. Domino. I gotta move through this PowerPoint. I don't know why it doesn't start it where I tell it to, but okay, so the next steps in this rulemaking process are additional workshops. I just wanted to note that previously the third workshop had been scheduled for April 13th. It has been moved to the week later to April 20th. The revised draft language from today should be available on this rules page, which is linked here under that written comments may be posted to this rules page. And it should be on there, I would hope, sometime within the next 2 weeks. We do have a commission meeting this week, Thursday and Friday, so it may be delayed like an additional week. And then a notice when that language is available will be sent via our Gov Delivery distribution list. Also on this rules page are the materials and recordings from previous workshops. The slide deck from today's AAGP presentation will be added to those materials, and then when it's posted to the rules page, then it will be available. I had a question about that. And then just additionally, as Dr. Domino mentioned, our focus at the April 20th workshop will be the new proposed section, which is WAC 246-919-604, which is titled Physicians Providing Advanced Procedure Support to Optometrists. And then if we get through that section, which we may in 2 hours, I'm not sure. We have had a lot of comments about that particular section, so it may take some time. But if we do get through it, then we will start again at probably section 475 in the draft. So that is our plan for the next workshop.
Great. Are there any questions about the schedule or the rules process? Seeing none, if there's no one else who wishes to speak, I will close the workshop. Thanks so much for joining.
Thank you, everyone.
Bye.
Hi, everyone. Thanks for